This conference will now be recorded.
So as I was saying before, Jake kindly reminded me to put the recording on. We usually start with new people, and Alan is kind of new, but he's not at all new to me, and is on the advisory board, and is also known to many of you who frequent the forums. Certainly Health Unlocked. And before that, it was
Healing well.
Healing Well. Thank you. I was trying to dredge my mind, Alan. Healing Well. That's right. And I mean, I happen to know that Alan is not an advanced patient. Alan is on our advisory board. I might have mentioned that. But if you are comfortable and you'd like to talk a little bit about your own situation, we'd like to offer you the courtesy we offer to everybody, which is just tell us a little bit about your background.
Sure.
And then, we'd love for you to participate just like anybody else would participate. And then we'll run down and see who has questions for today. So, Alan, I'll let you start.
Sure. I was diagnosed about 8.5 years ago with low risk prostate cancer, which was Gleason 6, and I think it was 8 cores out of 17 or 9 cores out of 17 were positive. No more than 40%, I think, in any one core. And I talked to an array of urologists and radiation oncologists, and finally settled on SBRT treatment, which is done in 5 treatments. And thank God I don't have any lasting side effects from that other than dry orgasms. But no urinary, rectal, or erectile dysfunctions. And I'm entirely happy with the course of treatment I got. As Rick said, I have an online presence. I participate in forums and write a blog, which some of you have seen. And I keep up with what's new in the field. I've gotten to know a lot of doctors over the years, and have good working relationships with doctors. I go on patient visits often with people in my life support groups. I attend 2 live support groups, one gay and one mixed or straight. And I often volunteer to go along on doctor's visits. And as you all know, when you go on a doctor's visit, you should always bring someone with you, because the doctor says cancer, and then you hear maybe a quarter of what he says after that. And it helps to have someone there who's listening and asking good questions and helping you along. So I do that for people in my support groups. And I'm on the board of the advisory board of Answer Cancer. uh, thanks to Rick. And
Thank you.
and that's pretty much it.
And Alan, tell us how you developed such an excellent lay knowledge of matters around radiation.
Well, I hope it's not just radiation, although on the new prostate cancer info link, Mike Scott wanted me to just write about radiation, but on my blog, I write about other topics as well. I just keep up with the field. What's helped me a lot is I spent about 20 years in marketing and market research. So I'm very familiar with statistics, and I have I have an undergraduate degree in biochemistry, so I have no problem reading these very technical medical reports and translating them into, I hope, into an easily understandable language for the average patient. I think those are what really helped me a lot in writing my blogs and making them understandable.
Mm-hmm. What I thought we might do before we just do a quick round robin is, since many of you know Alan usually signs off on the health blogs as Tall Alan. Is that correct, Alan? That's yeah. So if any of you have any specific questions that you would like to ask him in person, now is a great time to do it, because I know there are people on the call tonight who have followed Alan's blog for a while. Before I do that, I just want to welcome, we have one person that has called in who's on the telephone, and just wondering if you'd like to identify yourself.
Sure. Hi, Rick. John Appler.
Hello, John Appler. How are you?
Really good. Thanks for the research you published in email. Appreciate that.
Oh, that's a pleasure. Okay, so thanks, thank you, Jake. Okay, so anybody have any questions? Len, anything you would like to ask Alan now that you can virtually see him?
Okay, Alan, first question. How tall are you?
I'm 6'3". How tall are you?
6 foot.
Okay. So am I the tallest one in the room?
Sorry?
Am I the tallest guy in the room?
Well, Jake Hannon's got you matched. He's also 6'3", right, Jake?
Well, I was before I started stooping over from, but yeah, I was 6'3" at one time. I have a comment for Alan, if you don't mind. First of all, if you know, when people, if you can't take someone with you, I always recommend you take a recorder and ask the doctor if it's okay to do that. Some states make it, you know, kind of iffy about that, so you got to make sure it's with their permission. And the other thing, the blog, I know I've seen you on Prostate Cancer Link, and I know how to get the health unlocked and healing well, but do you have another blog of your own? And if you do, could you put it in the chat box? Is there a specific link?
Sure. I'd be happy to. How do I do that?
I'll do it. I'll put it in the chat box for you.
Thank you.
Okay.
Okay. But you can talk about it right now. Tell people a little bit about your own site.
Oh, well, it's called Prostate Cancer News, Reviews, and Views. there are maybe, I don't know, 300 to 500, I don't know how many, blogs in there about all kinds of topics. The best way to find something is to use the search bar. I usually am able to access things that way. Let's see, the most recent thing, we were just talking about this. The most recent thing I wrote is, what I generally do is I review important new research studies and put them in context, and I try to evaluate the research, because not all research is the same. You know, like a randomized clinical trial is not the same as a mouse study, for example. So I try and put them in context and say show what else has been found in this. Where my blog differs from the prostate cancer infolink blogs are that when we do things for the infolink, it's sort of one and done. What I've been trying to do in my blog is go back and update each one as new data comes in. So, for example, someone just asked me, what do we know about pelvic, uh, salvage pelvic therapy? And, what I've done on the site where that I sent him is I have several updates, or like lutetium 177 as PSMA. As new data come in, I update those blogs so that there aren't a whole lot of different blogs about it. You can go to just one place and see it all.
Just for those of you who are on the telephone, I'll give you the URL. It's https P is in Peter, C is in Charlie, N is in Nelson, R is in Richard, V is in Victor. That's PCNRV period blogspot.com. So again, https PCNRV period blogspot.com. And I think that's really helpful. I mean, I know we've got a couple of people on the call today that are probably pretty interested in lutetium 177. And I know for me, it is more of a challenge when I go to, say, Prostate Cancer International, and I find 3 or 4 or 5 different posts. I've got to make sure that I'm checking them out in the correct historical order, and updating. So the benefit of having somebody, the webmaster, the blogger, already do that for us is huge, and we really appreciate that. Len, did you have a serious question? Not that Alan's height isn't serious; it's very serious. But did you have any other question for?
Well, yeah, as long as you're allowing me to be selfish about this, Alan. This weekend I'll be flying down to the NIH for participation in a clinical trial for the scanning agent 18F DCF PYL, which I learned from your blog is probably the most sensitive scanning agent available at the moment.
And that's one of the few places. Well, I'm sorry. Go ahead. Go ahead.
No, you go ahead. That was just
Um, the right now there's a national trial going on of DCF-PYL. Let's call it PYL.
Sure.
And for those who don't know, it's a PSMA-based PET scan, probably the most accurate one, although that's why they're doing clinical trials to determine if that holds up. But based on early trials, it's the most sensitive and specific one so far. And there is a national trial going on. When you're in San Francisco, is that correct?
No, I'm in Connecticut.
Oh, I'm sorry. Yale, I think, was testing it. Did you look at Yale?
I did, and they wouldn't take me because their protocol calls for a minimum PSA of 2.0. I'm at 1.28.
Now,
The NIH trial is taking guys with a PSA of 0.5 or higher.
yeah, and the PY. Let me quickly look that up. The uh, could you look at the clinicaltrials.com?
Yes, I did.
Right. So I'm looking at it now. It's for recurrent. Right. And it's only at Yale, but they're telling you that, oh, because your initial treatment was with radiation?
Yes.
Oh, right. Okay. Right. It's 0.2 if your initial treatment was prostatectomy.
Right. Yeah.
So the NIH trial is wonderful. I think Johns Hopkins is also going to be starting another one. They developed the PET indicator, so they have an economic interest in making sure it works and gets approved.
Okay, can I get another question in, Rick?
Go ahead.
So I had
We give our co-moderators a little leeway here.
I had 86 gray of radiation to the prostate and whole pelvic girdle.
Right.
And not surprisingly, as a result, I've had rectal bleeding.
Yeah.
I've been told that eventually it goes away by itself. So I've had it now for about a year and a half, still waiting. Every now and then I think, oh, I guess it's finally stopped. I'll have a few days where I'll be fine, and then I'll have some more bleeding. I know one of the guys on our call, he's on our board actually, Bill Franklin, had the Argon Laser therapy, and it seemed to have worked for him for the most part. It helped a lot. Do you have any recommendations, whether it be waiting still longer, or Argon Laser, or something else?
In general, I think that after, how long ago did you have the radiation, did you say?
I had it I finished in September of 2016. And then the bleeding started about 15 months later.
Well, probably enough time has passed now that you can do invasive therapies like that. They want to wait. Most radiation oncologists, I think, would prefer you wait at least a year after treatment before you put anything inside, because the tissue becomes very friable and can tear easily
Yeah.
with invasive procedures. But if I were you, I would see a gastroenterologist and talk to them about, well, three things I could think of. One is hyperbaric oxygen. Have you looked into that?
I did. I saw a paper on that. I didn't really like the statistics. It didn't seem to be as effective as the argon laser.
Yeah, but the advantage is it's less invasive. I mean, it's annoying because you have to go and sit in this cage for a number of treatments, but for the guys it works for, they swear by it. The problem is it doesn't work for everybody. Then there's Argon Laser, and there's Argon Plasma, and there's Green Laser. And some gastroenterologists specialize in one and some in the other. They're basically trying to resurface your rectal tissue, and sometimes that works. Are you getting a lot of bleeding to the point where it's really annoying?
No, and actually, I think at this point, it really just seems to be it's bright red blood, and I have a feeling it's an internal hemorrhoid.
Oh, well, that could be also. I went to a proctologist after I had radiation, and he told me I had internal hemorrhoids, and he just injected some liquid into the hemorrhoids, which felt very good actually. It's soothing and anesthetic, and after a few weeks of treatments, all the hemorrhoids were gone, and I wasn't getting any bleeding anymore. So you might try that first, because that's the least invasive of the procedures.
Okay, great, thank you.
You know, Len, it's funny. I think this is the Ancan board affliction, because you wrestle with it, Bill did, and it's one of the side effects that I've had, and it's a long time now. I mean, I think you've heard me say this before. I mean, I had irritable bowel syndrome before I even had treatment, and I also had over 90 grays between the. I'm not exactly sure if the grays are all comparable, because I had 45 odd grays from radiation, and then the rest of the grays through brachytherapy. And I think, Alan, you've told me that you can't just add them together, that they're different. It's different.
Right.
But I had 50 odd grays through brachytherapy. So either way, I got a lot of radiation either way, and I mean I still have bleeding after 10 years, and interestingly, when first of all my doc would not allow me to even have a colonoscopy for 4 or 5 years because he was worried about the sensitivity of the tissue and the risk of a fistula. So I did get a sigmoidoscopy first of all, and when they did that, I could actually see on the screen all the tissue that was irritated. I mean, it was a different color to the rest of the tissue. And, you know, at this point, and I don't think I've ever had hemorrhoids, but I do have bleeding. And I thought about getting the laser ablation, but I just decided, look, it doesn't bother me that much. I mean, what does bother me is the IBS. But and I think the IBS is worse because of the treatment. But I mean, I can live with IBS as the price for having what appears to have given me a durable remission. So I'll take that. But I think Alan's advice is all good, and I do think it might be worth looking at some other issues for you. Yeah, and also to talk about the doctor and say, well, look, if it's just the bleeding and I don't have any other side effects, do I need to worry about it? I mean, that to me is the $64,000 question.
Right. I have no other symptoms, no pain of any kind, no discomfort.
Yeah. So the question is, if you don't have pain, you don't have discomfort, is it worth intervening? I mean, what's the downside from just leaving it as it is? And a good either proctologist or GI doc is going to answer that for you. Well, anyone else? Let's move along. Anybody else like to pose any questions to Alan about maybe lutetium-177 or anything? Open season, Mr. Adele. Anybody there? Anybody else have a question for Alan?
Well, I might, Rick. You know, it's Ken Anderson.
Hello, Ken. Please.
Well, the question would be, you know, I've had IMRT like 72 grays to my prostate gland, but during the PET scan at MD Anderson in December, they found a little bit of activity within the prostate. So I've met with a local radiation oncologist here, and he's recommending doing high-dose brachytherapy to wherever the gland is, wherever there's cancer present. It's been about a year since I had, you know, IMRT. You see any problem with that or anything that I should worry about?
No.
Alan, hold on a second. Let me just fill in some more to that.
Go ahead.
Because Ken's only giving you the second half of the story. Ken was diagnosed metastatic with bone mets at age 54, right, Ken? 3 years ago?
No, 57. No, I'm sorry, 56, 2.5 years ago.
56. And so he did chemo, et cetera, and he's also a patient of Paul Korn's in MD Anderson. And when he did the IMRT, it was on the basis of debulking the primary. So I just want to give you the backside of it.
That does help quite a bit. So what Rick is alluding to, and the question is it really worth going after every last bit of cancer in the prostate? And, you know, there's not a lot of data on this. When when Rick said you were metastatic, how many bone mets were you diagnosed with?
5 question mark 7.
Okay. Yeah. The most recent trials, you're probably aware, HORAD and Stampede, showed that there was no benefit to any men who had any more than 3 distant metastases to debulking the prostate. Now, you know, I know a lot of patients are interested in radiotherapy to every last bit that you can see, but I don't know if that's really going to buy you anything. But, my feeling is that I understand why patients may want that anyway. The idea that there's still these large masses of cancer inside is, causes anxiety, and radiating that with HDR brachytherapy or SBRT or whatever tends to relieve that anxiety. I don't know if there's no evidence that it really does much to increase survival at all. But if you need to do that for your peace of mind, and if it's safe, and I really stress the safety aspect of that. I can't think of an argument against it, but I can't come up with a clear argument for it either.
So you don't really believe there would be any evidence like a PSA drop if within the PET scan that was the only area that had active evidence of, cancer?
I think PSA will drop if you treat that, but treating PSA is not the same thing as treating
I got
cancer.
ya. No, I understand.
So yeah, it's likely to reduce your PSA, but will it increase your survival? I sort of doubt it.
All right.
If it's something you want to do for peace of mind, and if your radiation oncologist is convinced that it's safe and will give you very few side effects, my feeling is go ahead and do it.
Well, I don't want to do it for the fun of it.
Well, but anxiety is a big part of living with.
No, I'm well aware of that. I am well aware of that. So,
But I think the HORAD and the Stampede trial showed that there's really no benefit in debulking after multiple bone metastases have been discovered.
okay, well, thank you for your time.
Sorry, I can't give better news.
No, it is. I'm pretty much a realist. I just want to know what it is what it is. I'm gonna, before I commit to it, I'm gonna send another little note off to Paul and get his 2 cents as well. So, and if his comments right in line with yours, I probably will tell this oncologist that, because quite honestly, I don't want to take the risk of doing any damage and having additional side effects if in fact that's possible. So, and if it's not going to provide any overall benefit, then why in the hell would I do it?
Yeah. I think, Alan, his answer is very much in line with what we've said on here, Ken. And although we weren't able to quote the oligometastatic trials like Alan. Oh, I shouldn't say that. Len probably could have quoted those trials for us. But I think what we're going to do, Alan's going to stay with us, and let me see who would like some time today, and then I will ask Alan to chip in. I'm sure he will, as we discuss the issues that come up in the course of the rest of the call. So
Wait, can you tell me how I can send? I have a blog about this,
right.
the debulking thing. How can I send that to Ken?
You can send it to me and I'll forward it to Ken.
All right.
Does that work? If you send it to me and then I'll forward it to Ken. That'd be great.
All right. I will do that right now.
Thank you.
Now,
All
Rick,
right, thank you very much.
Rick, this is Mark Finn. Question: when you talk about debulking, you talk about debulking the prostate or any of the metastatic tumors?
The prostate, I think. Go ahead, Alan.
Yeah, the prostate.
Okay.
Debulking refers to the prostate.
Okay.
There's another thing called oligometastatic treatment, which I would call like whack-a-mole, going after each metastasis as it crops up. But that's a different thing.
Okay. Because I had SBRT for a bone tumor, not for the prostate. So I was just wondering what you were talking about. Okay. Thank you.
Okay. So let me run down and see who'd like some time, and then we'll go from there. Jake.
No, I'm still waiting for my Axeman appointment. I'm waiting for them to schedule it. I don't know if they're sending to China or what to order this stuff, but other than that, I don't have anything.
Okay. Well, and how about your anxiety? Can we talk about that? Can I come back to you and can we talk about that a little bit?
Sure.
Okay. Carl Foreman, is there anything that you'd like to raise tonight?
Yes, sir, please.
Okay. Dennis, anything you'd like to raise tonight?
Yeah, give me a 5-minute for an update.
Yes, with pleasure. Len, anything else for you?
Nothing, Rick. Thank you.
Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Sylvester, anything for you?
No, thank you very much.
Okay. Jeff Dreyer, anything you'd like to raise?
Yeah, if we got time for it, sure.
There is time. There is absolutely time.
All right.
Ken Anderson, anything else that you'd like to raise?
No, that just about did me.
Okay. Mark, Finn, would you like to discuss something tonight?
I can give you a one minute update on mine when you're ready.
That'll be great. And Les Shelderup, anything you'd like to raise?
Not tonight, Rick. Thanks.
Okay. By the way, just for your information, Les and one of our board members who's not on the call tonight, Peter Kafka, for your information, Alan, both had in the last 3 or 4 months proton beam radiation for abdominal lymph nodes. So, which is radiation for the abdominal lymph nodes is somewhat unusual, and for both of them got SBRT, one following the other and independently is sort of interesting. So we have a good reference base on this.
Were those going after individual lymph nodes or treating the entire pelvic region?
Well, they had individual lymph nodes, but both were treated for the entire abdominal region, not pelvic, higher.
Higher. Wow.
Abdominal, yeah.
Para-aortic, Alan.
Oh, para-aortic. Okay. But because when you get really high, it gets to be a little dangerous because of all the organs in the abdomen and thorax. But yeah, there's a guy in my support group who first had his para-aortic, first had his pelvic lymph nodes done as high as the common iliac lymph nodes, which are about up to there. And then cancer was discovered in his para-aortics. So he had just the chain of para-aortics done with a boost to the para-aortic lymph node they found on the Axeman scan. And he seems to be doing very well with that.
Good. And I mean, Les had it done at Mayo, and Peter had it done in San Diego, both with proton. So, okay, so I asked Jake about his anxiety because during the week we talked several times, and at some point Jake mentioned to me that he wasn't feeling that comfortable, and because of the upcoming Axumin. And I thought maybe one of the nice things that happened for Jake over the past weekend is that he got to meet with Rich Jackson. Rich came up on his way up in Rolling Thunder on his way up to DC. He stopped by and the four of them spent some good time together. So I was hoping that might reduce the anxiety a little. But Jake, we all empathize because it's for people that don't like those tubes, knowing that you've got a tube coming up in your life is not easy. How are you doing?
Well, first of all, I did have a nice visit with Rich. I hope he enjoyed it. I know I did. But we didn't really talk about anything having to do with prostate cancer. Especially we didn't talk about tubes or anything. And I've been looking on the internet and looking at the pictures of the tubes and everything, and I realized that they're much wider and not as long as an MRI tube. So I think I'll do okay. I take a Xanax before I get down there. So I'm not big on driving either. And I might take a second one before I go into the tube. But from what I've read, and I think several people have confirmed, the whole thing only takes about 30 minutes from the time you get the injection till the scan is over. Probably for me, the hardest part is going to be holding my hands over my head for that long. I know that gets very uncomfortable.
Jake, as I recall, at no time was I unable to view at least part of the entire room that I was in. In other words, it wasn't like an MRI where you're buried in that tunnel and that's all you can see.
Right.
I could always see either above me or out the other end.
Yeah, to my recollection, Len, I think you're right. I did have a PET CT back in 2012, and I do seem to remember I could see my feet, or I could see the wall beyond my feet. And I think the only time I freaked out was I did fine until it got near the end when I had my head in there, I think, or under the scanner. But it's not nearly as long as the MRI tube, if I remember correctly. Do you remember that, Len? I think you've had probably every kind of scan there is.
It was only about 20 minutes, Jake.
Yeah. I meant the tube itself.
Oh, the length of the tube? Yeah,
Yep.
it's smaller. I don't know exactly how long, maybe somewhere between 3 and 4 feet in length.
Yeah. As opposed to a tube, the MRI tube is almost your whole length of your whole body.
Right.
Yeah. Well, I think I'll do okay.
Good.
Right now, since I don't have an appointment, I'm not having any anxiety.
Okay. As long as they can't
when you do go in there and then you get on the table, make sure you get as comfortable as you can. Get, put a little pillow under your knees. It's helped me. And because I've had some cervical issues in past years, I asked for something under my neck to get me, just about as comfortable as I can. And, putting your arms up over your head, you could, before you go, start doing a little stretching, but, while you're laying down, and just get some of those muscles loosened up a little bit by putting your arms up over your head like you would. That might help.
Okay. Yeah, well, I definitely want to have a pillow under my head. I don't know about my neck, but I definitely want one under my head. Why do they ask you to put your hands above your head? I don't understand that.
I think it's to keep them out of the way as the table moves back and forth. You don't get them hanging off the edge of the table and get them pinched or something. I don't know.
Oh.
I have a question on that. It's an absolute requirement. When I've done about 10 of the PET scans, and that's supposedly a requirement there also, where you have to have your hands above your head. And I said, I can't do that. And they said, okay, well then put them along your side. And that's what I've been doing for 10 scans now. Just had them alongside my body.
Okay. Does that make it more comfortable for you?
Yes, I can't hold my hands above my head for more than maybe 2 minutes max.
Right.
And I don't know what happens to my shoulders, but just very painful.
Okay. Well, I'll see if they'll let me do that. Thank you, Les.
And Jake, now that I think about it, they gave me a kind of U-shaped bar that I could hold in my hands and rest on my body, so my arms stayed away from the sides as the gurney moved back and forth. So you can ask them for that.
Say that again, Lynn. A U-shaped bar that did what?
You put your hands on the bar. So in other words, your hands can't go flying out. Your hands are on the bar. You're holding it while you're moving in the tube.
Oh, okay. Thank you.
Okay. Sounds like some sort of a dipstick. If you start steering with it, maybe the tube will take off. I don't know.
I think I'm playing a video game.
Well, I guess as long as they can't get the contrast, you don't have any anxiety. So that's a good thing, huh?
As long as what?
As long as they cannot get the contrast, you don't have any anxiety. So it's a good thing. The contrast is the medium that they want to put in, that they're trying, whatever this medium is, they're trying, yeah.
Oh, right, Axamin, right, the F18 something or other. Everything's got an 18 in it these days, but yeah, fluorocyclidine, I think it's called.
Yes. Yes.
Yeah. I don't know why it
Okay.
takes so long.
Anyone else have any good words of wisdom for Jake before we move along? Okay.
Thanks, guys.
Well, Jake, keep us posted when D-Day emerges. Please keep us posted and let us know, okay?
I will. Thank you.
Carl, why don't you give us a little update on what's going on? How are you doing?
Okay, well, I was at my doctor's office about an hour ago as a follow-up, but several weeks ago, I was having a pain in my leg that.
Hold on 1 second. You'll need to give us a little bit of background, at least for Alan, because Alan doesn't know your history. So give us the elevator version of your history.
Well, since I know Alan very well, he probably knows me very well on the Health Unlocked. As hoping for the best one. So I posted multiple times on there with my background. But anyway, oh boy, I guess the short version is that I've been in a clinical trial at the Rutgers Cancer Institute. Back in November of last year, I had a robotic prostatectomy, in addition to having been on Zytiga with prednisone for several months prior to that. Just before the surgery, my PSA had dropped from 20 to 0.12. Right after the surgery, a week after they did the PSA, it was 0.15. Asked them about it. They said, well, it's not unusual that it happens after surgery. It continued to rise in increments, accelerating to 0.55 about 3 months ago. And at that point, at the recommendation of Rick here, I reached out to Dr. Dumchek at the Philadelphia Abramson Cancer Center, who's an expert on BRCA2, so which I know I am because I had genetic testing. So several things are kind of against me with that diagnosis. So as of a couple of weeks ago, so I'm on olaparib now. I've been on it for 3 months. After about 2 months, my PSA went to 0.02. And that's my latest PSA. It was about a month ago. So a couple of weeks ago, I was having pain in my upper left thigh, and I would only feel the pain when I would go to sleep, not when I'm standing or anything. But it was annoying enough that it was causing me not to sleep well. Went to the doctor. I spoke to the oncologist. The oncologist said, well, in addition to the pain in the thigh, I was having some edema in the foot, in the left foot. He said, well, let's get a renal Doppler just to make sure there's no blockages. That was done, and it showed clean. My pain continued on, and I went back again to my primary care. Now I went to my primary care doctor, and that was as of last week. And the doctor recommended, oh, let's do a Doppler. I said, well, I just had it a couple of weeks ago. They said, doesn't matter. And thank goodness they did, because they found a partial DVT in that location in the thigh, and they put me on Eliquis, which is a blood thinner. And I've been on that since this past Thursday. I had a follow-up this afternoon with the primary care doctor and asking how he was doing. I had some blood work done as well. And I said, well, the pain is still there. It's somewhat subsided, but I said, well, it's going to take a while for the blood clot to dissolve, hopefully. But I have to be careful. Now that I'm on the blood thinner, I have to be aware that I could be susceptible to any kind of heavy bleeding if it's a small cut or anything. So in addition, they did take blood for me this afternoon. I have a bandage on it, and it is definitely a little more blood there than what I've had in the past. So the blood work that I had also showed some low levels of RBC, hemoglobin, and hematocrit. So that says I'm anemic. And in addition, for my urine, my pH is high at 8.5. So the oncologist basically attributed all of this to hormone therapy, and nothing to be alarmed about per se. So the primary care doctor also kind of said, really the ratings are not anything of a great deal of concern and not surprising. In addition to the blood clot, I've been told not surprising because that's ultimately a side effect. I never thought I would get it and kept it out of my mind, and here it is. Now I have a blood clot. Although it's a partial blood clot, and they say that based on the Doppler that they can tell that there is flow, and it's on the side of the wall of the vein. So that's what I'm dealing with right now. I'm actually going tomorrow to Columbia Presbyterian as a follow-up, just in general, with the oncologist, Dr. Stein, and see what things he has to say as an update. So that's where I'm at.
Whoa. Well, look, just a couple of things. Whilst the deterioration in your blood counts definitely is a function of LHRH, we know that. I think it's probably exacerbated. Your doctors might well agree that it's exacerbated by the olaparib, the PARP inhibitor, because we know 2 or 3 instances of people who have been on PARP inhibitors and their blood counts have plummeted, and everybody's different. So that's. But I just want to make sure that when you factor all this in, it may not just be the LHRH drug, that the olaparib is probably playing a part in this too, Carl.
Yeah, and there is one other component, ALP, alkaline phosphatase, which when I started all this, it was over the limit. It was very high, indicating evidence of problems with calcium in the body. Now it's below normal at 36 versus a low of 39. So there's just showing, well, that's evidence of bone disease. I thought if it was low enough, that was a good thing.
So now your ALK is showing, your Alp Phos is showing is very low rather than very high?
Yes.
I mean, most of the time that I'm familiar with, that when the Alp Phos reflects bone activity, and that can be metastasis, or it can also be bone repair. So you're never quite sure. So somebody who, for example, is getting a treatment, an advanced prostate cancer treatment, where the treatment is actually nailing the cancer in the bone, is going to show Alp Phos, just as somebody who might have serious disease that's not being treated would show a high Alp Phos. Low Alp Phos, I really don't know much about. Alan, do you know much about alkaline phosphatase activity?
Just what you said, Rick. Do you have bone mets, Carl?
Yes.
Okay. So
yeah, I'm on Xgeva, and also the last time I was on, I was discussing my PET Aximum scan that I had back in March, and where it came out with some spots in the skeleton, but it was not conclusive, where they had nothing to compare against, and the radiologist admitted, he said it could be healing spots in the bone structure. So
yeah, and they're blastic bone mets, not lytic bone mets. Is that correct?
yes.
Yeah. I'm completely at a loss. I don't know why it would be low, but it doesn't sound very low.
No, correct. It's not very low. All right.
So, I mean, it sounds good, actually. The only thing I worry about with blood thinners is internal loss of blood, which could let make for low hematocrit and hemoglobin. But again, it doesn't sound very low, so it doesn't sound like there's anything to worry about. The one thing that they do have to worry about is the clot, making sure that it dissolves before it moves up towards the heart and the lungs. But I'm sure they have an eye on that.
Yeah, I mean, they did say they're going to follow up with another Doppler in 6 weeks. I was kind of disappointed. I have to wait 6 weeks, but other people say, "Oh, it's been even longer than 6 weeks." So I guess I'm happy with that.
Right. You know, in that regard, I think it took around 2 to 3 months for the clot that was actually in Bill Burhan's heart to dissolve. So they just saw that a week and a half ago. Yeah, I think when I spoke to him last week. So he was very happy. In fact, he even emailed me and said, "Oh, they just did some more scans, and the clot seems to have dissolved. So they've taken him off the blood thinners," which he's very happy. But I think it was a good 2 months, if not more, that he was on those blood thinners. You know, I just don't know. I don't understand enough about this clotting process and to what extent it's attributable to the LHRH drugs. Does anybody have any insight on that or any comment on clotting and the LHRH drugs?
Yeah, this is Dennis. When I had my blood clots in my lungs when I was taking the chemo docetaxel, the doctor told me that it was likely due both to the prostate cancer itself as well as the chemo and the let's see, I think I was still on Firmagon at the time when I had mine, and I had to go on a Lovenox daily injections for a safety factor. There were some of the blood thinners can give you a problem if you eat certain foods with them. And I right off the top of my head, I can't remember it, but they felt that was the safest approach to my situation was the Lovenox injections. And that went on for, I think, a couple of months. And I was really glad. There is a blood test that they do to see, they call it, they see it's dirty. They call it, when they call it it's dirty, it means they're seeing little particles of the blood clot dissolving and that it's working. And then when it comes finally, it's clear, there's no more dirt, so as they call it. You can get off the blood thinners.
Okay. Yeah, I mean, I'd just like to know more about why the cancer itself actually causes the blood clots, and I guess I'm going to have to do some research. Len had to sign off early for his son's birthday party tonight, so I will get hold of Len and I'll ask him to do the research. He's my
Rick. The cancer puts out anti-inflammatory or inflammatory cytokines, which do cause clots. So that's that happens in almost all of advanced cancers.
Okay, thank you. And it's not peculiar to prostate cancers. In other words, it's relatively common across the board for advanced cancer.
Yeah, I think that is. I remember that with both of my parents that they had to watch for that.
Okay. Okay. So yeah, I mean, uh, Carl had asked me offline about how Bill is doing, and Bill was on Lovenox as well. He was giving himself the shots, and so as I said, he seems to be doing better. Although I got an email from him yesterday where he said that he's still suffering a few side effects from last week's chemo infusion. The other problem Bill had, Carl, is that because his urinary tract is so shot from the radiation, that he had some excessive bleeding when he was on the Lovenox. But I think that is probably compounded by the very poor condition of his urinary tract.
Right.
You know, from Alan, Bill, I don't think you know Bill. I'd love for you to meet him. But Bill is a cancer research professor at Roswell Park. And he's used a couple of drugs, including olaparib, that he has actually researched over the years. And he's BRCA positive germline. And he's firmly of the opinion that men or anybody who carries a germline BRCA mutation, that their cells are a lot more susceptible to radiation damage than those who do not carry it. So,
You mean they're healthy cells, so the toxicity is higher?
exactly, the toxicity is higher. Since every cell carries that BRCA mutation, if it's germline, all the cells, and it has something to do with the mismatch repair. I don't understand it well enough, but I understand the concept is that the mutation compromises the integrity of the cell, and it makes people with a BRCA mutation more susceptible to damage because the toxicity is higher.
There's a related kind of a germline problem called an ATM mutation.
Sure, yes.
Which is a definite contraindication for having any kind of radiation,
right,
because the damage would be so great. But I can see how I've known several men who have had BRCA mutations who went through radiation just fine.
Yeah.
It's definitely something worth being careful about.
Right. Interestingly enough, Bill, the last trial Bill was on, which did work for a while, which was out of Dana-Farber, was with an ATM inhibitor in conjunction with olaparib. And it was Bill's lab that had found the pathway to make that ATM inhibitor effective in around 2007 or 2008. And I don't know if Bill does have an ATM mutation or not, in addition to the BRCA mutation. I would have to ask him.
Rare. BRCA is much more common than
right. ATM. Okay. Anybody else want to say anything to Carl about thoughts on clots or any experience they've had, or anything else on the clotting subject?
I do remember Dr. Steve talking about the alkaline phosphatase, and the lower it is, he always thought was better.
Right.
So
right, but the question is, what about if it's below? Yeah, but the question I think is, what if it's below the normal range as opposed to above the normal range? Is the question. I mean, what Steve, God rest his soul, always used to say, you know, was looking for it to be within the range. But the issue that Carl is looking at is that his Alp Phos is below the normal range.
Oh.
And that's really something which is unusual, and I don't know what the reason for that is.
I think it has something to do with bone turnover.
It does.
Yeah.
It does.
I don't know if there's too low, but you know, a low means it's not your cancer's not doing a whole lot of churning around.
One thing that maybe Alan will just inform you on, since he used the terms, because a lot of people may be confused, is Alan, can you just tell the gents the difference between blastic and lytic?
Yeah, most kinds of prostate cancer result in blastic metastases, which means the mets increase the bone size over the normal size. So there's bone overgrowth, which tends to be brittle, and you can get fracturing because of that, which is why one takes Zomito or Exgiva for that. Other kinds of cancer and some rare kinds of prostate cancer, like neuroendocrine prostate cancer, result in lytic bone mets, which means the bones have a net decrease in size. They tend to be thin and also fracture easily. But so lytic bone mets, the kinds that get where the bone gets thinner, tend not to be due to prostate cancer, except in rare cases.
Right. Thank you. Thank you for that.
Alan, could I ask a question? With the lytic bone mets, would those show up the same way on a standard bone scan, or you need something else?
No, that's a very good question, Jeff. Because bone scans, they look for bone overgrowth, which may be due to metastases, but are also due to things like arthritis or injuries to bone. You could have had a broken bone in childhood, and which will show up on a bone scan. But lytic bone mets tend not to show up on bone scans, but they will show up on CT scans. So, and they always do bone scans and CT scans together, so that they can look and see if the bone seems to be to have dissipated or dissolved away in any way on the CT scans. That will immediately pop out.
Okay, thanks.
Thank you. Yeah, no, thanks. And the interesting thing is, and because I asked my buddy one time, one of my closest friends, lifelong friends, is a cancer surgeon, and I asked him about the condition of the bone when they go in and they're doing surgery and they see the cancer in the bone, and he sort of said it's kind of like marshmallow, and that the bone is there and it's larger, but the quality of the bone is just not good when it's infected with cancer. And so it's softer and it just sort of scrapes away. The mass is there, but it doesn't have the strength in it. So, okay, we will move along unless anybody has anything else to say to Carl. And Dennis, give us your, please give us your update.
Yeah, I had my blood work, my 90-day blood work come back, and PSA is holding at less than 0.1. So that's the good news. All the other metabolic panels and all the blood work was fine. Everything was in range. No issues there. So I'm continuing to tolerate everything well. My Lupron and prednisone and Zytiga. I do have minutes before I got on the call, I got the mail and opened, I got a letter from my local oncologist that I use just to get my lab work done and my Lupron injections. And he's leaving. So it's going to be, again, looking for a local guy, hopefully. I mean, if all else fails, I'll just have to go up every 3 months to Mayo and see my main guy up there.
Right.
But as it is, I will be seeing my local oncologist for the last time tomorrow afternoon. That's my scheduled appointment for my Lupron injection.
Yeah, for your Lupron shot. Well, first of all, we're delighted that you're holding in there. How long have you been on the Zytiga now?
2 years.
2 years.
Over 2 years.
It's great.
Yeah, 3 years since my chemo and everything. So
yeah, that's awesome.
Yeah, yeah, my hope is that this stuff just keeps working long enough. I know it's not a cure, and but if it can keep me alive long enough till something like this, was it ISRIB drug that they're working with the mouse right now? So I guess the question for Alan or somebody would be, typically, how long is the period from the time that you get something that's working with the mouse till you get it where you can start the trial with humans?
Oh, a long time.
Too long, I know.
Yeah, I mean, they may start the trial. If it was successful in mice, they may start a phase 1 clinical trial within a couple of years, depending on IRB approval. And then it has to move through phase 2 and phase 3. And so it could take 7 to 10 years before anything becomes available because of it.
I may be wrong, but I think when I read that article, it is an existing drug, so that you might be able to use it off label.
Yeah, it's used for memory problems, I think, right?
Yeah. So you might be able to get it off label. It's not like it's a brand new formulation or a brand new drug.
Yeah.
Well, again, it's great that this continues to work for you. I do have an important question for you, though. How you've been on the Zytiga and the prednisone 2 years. How has your golf handicap changed over that 2-year period, Dennis?
My handicap has gone up.
Oh, the handicap's gone up.
Along with the growth in my abdomen.
Yeah.
I keep hitting the end of the golf club against my abdomen when I swing.
Okay. All right. I'm just checking. I'm just checking,
But I'm still in the money. I'm still in the money. I got second place this last round and first place the round before that. So.
Okay.
It's good to have a higher handicap,
That's right. That's right. Bit of a ringer in there. but seriously, it's really good, and no problem with your blood counts. Everything's normal and looks good.
Great. Yeah, that's the good thing. I mean,
You know,
I still have all the symptoms that go along with those treatments, and hot flashes and memory
right.
issues, cognitive issues, the weight gain in the abdomen and all the other good stuff that goes along with it. But heck, I could deal with that.
Well, I would say to you, if the hot flashes are really bothering you, do try acupuncture because you may get some temporary relief from it if it works. I mean, you have to go every 2 to 3 weeks, but I do know a lot of guys that have had success with that. So,
Yep.
Go ahead, Dennis.
Yeah, I'm aware of that. Yeah.
Okay.
I think it's an inconvenience for me. It's not a total.
Right.
I wake up
Right.
once a night or something like that with it.
Right. In terms of finding another doc, I think the best thing to do. Well, first of all, is this doc leaving Tucson,
Well, see,
or
I'm gonna
is
I will find out tomorrow at my appointment with him and find out where he's going. He's presently with Arizona Oncology,
right?
and I think he's been looking around. He's really good, good with patients. He's really sharp, and it doesn't surprise me that he's looking for greener pasture someplace here. He's a young guy too, and
Okay.
I would be surprised if he is good friends with
Dr. Singh.
Dr. Singh. Yeah.
Yep.
So maybe he's going to Mayo. I don't know.
Well, if he's staying local, maybe you can follow him. If
Yeah.
not,
Yeah.
then ask him who he would recommend that would work well with Dr. Singh, because you're not going to leave Singh,
Right.
and you want a local med-onc who will work well with your GU med-onc.
Right.
So
Yep.
see what he
That's the
suggests.
plan.
And if you have, if it really, if you come up without anything, let me know and I'll check with my buddy Steve Wool and see what names he suggests, because he understands the issues and he might have some ideas too, because he knows these doctors really well. So, okay.
Yep. Thank you.
Okay, let's move on to Jeff.
Hello. Okay. Yeah, I'm, let's see. Well, a little bit thumbnail sketch. The background is, so I was diagnosed in early 2017 with Gleason 9 over the entire gland, prostate. Some what looks like extracapsular extension going on. So then I had I enrolled in a clinical trial of radiation therapy, hormone therapy, and enzalutamide. And so I began the hormone therapy in May, which is Lupron. The Lupron and enzalutamide had started in May of 2017. I had IMRT over the summer, 5 weeks, and then HDR brachytherapy, I think 11 catheters of, cobalt 137, whatever it is. So totally fried my prostate gland. The usual expected side effects, which subsided over the next couple of months or so, mostly. And my numbers went down in the favorable direction. My PSA has been undetectable for about more than a past year. And my other blood work is within normal range, except of course testosterone. And so right now I'm feeling pretty good. My energy is, so as I said, May 4th, I stopped the enzalutamide. My last Lupron shot was on December 28th last year. So I think my energy is starting to come back somewhat. But my big concern actually right now is having to do with ED kinds of issues. And I'm just wondering about how that will unfold. I read various things that, in the absence of a concerted exercise program, that you run the risk of all kinds of tissue damage, which can be permanent and so on. And frankly, my libido has just been zero to the point where I couldn't bring myself to exercise, so to speak, even. My libido is still very low, and my ability to perform such exercise is also almost zero, except on a rare occasion with my partner. But it even seems that things like Viagra and Cialis don't have much effect on me. So I'm just kind of worried about how this is going to go, and if this is the rest of my life. Yeah. So that's my spiel, my questions.
Well, a couple of things I just want to say before we address the ED. I'm assuming that you're tailing off the prednisone. Oh, you were never on prednisone. You were on enzalutamide.
Right.
Okay. Perfect. Right. So you don't have to worry about that. Secondly, your last shot was December.
Yes.
Of 18, and was that a 90-day shot?
Yes.
Okay. So that's going to take you through to March. And when you've been on this long, it takes a good while for your testosterone to really pump up. Have you measured, when was the last time you measured your testosterone?
Yeah, I think it was in April, and it was like 15 or something. Yeah.
Right. So it's going to take some time to come back. And I think that as your testosterone comes back, hopefully your libido will come back, and to some extent your sexual performance, and your musculature and everything else. Now, I am not the best expert here on ED issues. Peter and some of the people on the other call are, and maybe that was why you were on the other call yesterday. I'm sorry we didn't get to you. I'm sorry you had to hang up.
Oh, that's all right.
But I'd encourage you to also add this question on the low intermediate call, because there's a lot of knowledge on that call. There are certain people on this call who do have knowledge, but with the exception of Alan, I don't know if any of those folks are on today, but we're going to open this up momentarily. But the first thing I do want to say to you is give yourself time. I know in my own case that my LHRH wore off around February, and in May I still didn't have any testosterone, and my PSA wasn't measurable, and by August, which was 6 months later, I was feeling way better. So it's still really early days, Jeff, and so don't intuit any permanency into how you are right now. Let me let me open it up. I mean, probably Alan from his group has more experience in the rehab process than I do.
Yeah. In fact, someone in my group is taking Zytiga along with his radiation therapy, and Zytiga and Lupron along with his radiation therapy. Now, his concern was mostly size loss, which can be a problem when you've been on long-term hormone therapy. Penis length and girth tends to shrink with disuse. So what he does is he uses a pump every day. Now, my heart goes out to him because I know he has no libido. So using a pump can be like a chore. To me, it would be a chore even with libido. But some guys grow to enjoy it. But it does keep the penile tissue aerated and gives it a better blood supply, so that he's not seeing any size loss, at least. Now, in terms of erectile function, he can still have erection. He also has some trimix, so he can get erections if he wants to. The problem is the libido. He just doesn't want to. But one doesn't necessarily have anything to do with the other. You can have no libido and you could still get erections. You just won't want to. So,
Right.
So I mean, I wouldn't worry right now if you're taking ED meds and trying to masturbate or work with a partner and things just aren't happening. That can be because of libido more than erectile function. If you want to test erectile function, try mix. I mean, but there's no reason to believe your equipment wouldn't work, although it can. I don't want to minimize the erectile function loss due to radiation, because it does occur. It just doesn't occur as much as with prostatectomy. So, but right now there's every reason to believe you're fully potent. If you were fully potent before you had the radiation.
Yeah. Yeah, that's why this is such a peculiar phenomenon for me. So,
I mean, for your peace of mind, you may want to just try some trimix to see.
So my impression was that the trimix works even if you have vascular damage and things.
Well, it won't work if you have vascular leakage.
Leakage, yeah.
Yeah, because it creates an artificial situation in which blood comes into the penis, but if you have vascular leakage, it will go right out. So, yeah, you may get an erection, but it will only last like a minute or two. But if you use Trimix and you don't have vascular leakage, you should get an erection usually much longer than you want it to be there, which would be a
Right.
problem on the other end.
Sounds like a good experiment anyway.
Yeah.
Yeah.
Uh, it- a bottle of Trimix, you should be able to get it from your insurance. I don't know how much they cost if your insurance doesn't cover it, but I mean you could try it and just see if it works. Or Muse, are you familiar with Muse? MUSE?
I've heard
It's
of it.
a
Let me
pellet
see. Yeah.
that
Yeah. Oh,
that
yeah. Those things, the pellets.
goes
Yeah. Yeah.
into your right.
Right.
Massage it in. It's
Hmm.
it's basically the same chemicals as in Trimix, but it doesn't involve an injection. It also doesn't work quite as well. But some guys are a little nervous about doing the injection.
All right. Well, maybe I'll go talk to Dr. Tom Liu again. I saw him once, but over a year ago. So
Well,
time to
I
check in
was,
with him.
yeah, you probably saw I put that in the window.
Yeah.
And he is one of the best.
Okay.
And as is, I forget his nurse practitioner, but she's also very, very good. If you do have to see her, she's got a great rep. I've just lost her name for the second. But she's very, very good. And there's also there's a good pamphlet that they put out that I've linked in the window on managing impotence. But I do think that you can certainly get the Trimix through Tom Liu, and he has a great reputation. And you're a UCSF patient. And the other thing is that he's going to have a pretty good feel, a much better feel than we do, for what is a reasonable expectation when you've been on an LHRH drug for as long as you have. I mean, a year and a half or more. When he'll set your expectations to a more realistic level, and he'll also be able to work with you on penile rehab. So I think that Tom Liu is a great starting point. And then, like I say, do join the other call. There are a couple of people on that call. Our resident expert was Jim Harrington, God rest his soul, and we lost him last year. And he used to be on the call regularly. But he had some very good input on all of that. Do be careful with the Trimix, because I know people that have had really bad experience. One piece of advice that I've often heard given is that the first time you use it in the doctor's office. I think that's probably worth bearing in mind. I mean, I do know people that have had some really nasty issues and finished up having to go to the ER and goodness knows what. So, and also the other thing is everybody's sensitive to the dose. I mean, it's, there may be a suggested dose, but everybody is different. And so what might be a normal dose for one person might be an excessive dose for somebody else, or an underdose for another person. So
there's also Bimix, BIMIX, which is only 2 chemicals, I believe. Some people go to that when they have a problem with the Trimix.
Okay. Yeah, I mean, again, this is not my area of expertise, so I honestly don't know. But I can say that Tom Liu is really good.
Okay.
Well, how was your experience with Tom Liu?
He was funny, affable and encouraging
Right.
and all of those things. He told me to take my penis to the gym when I told him that I didn't have any interest. And well, I just never did that because I didn't have enough interest. So yeah, so maybe I'm just concerned that maybe I've caused myself irreparable harm through neglect at this point, but I guess I'll go back and have another appointment with them.
Yeah. It's probably the right time. And you know, keep coming back here for ideas, and to Peter's group for ideas as well.
All right. Yeah. Thanks.
Anybody? You know, we should open this up a little bit. Has anybody got any suggestions or thoughts for Jeff?
Did you say you're taking an ED medicine also, Jeff?
Oh yeah, I take very small 5 milligrams Cialis every day.
Cialis, okay, right. Alan
And
mentioned
yeah,
keeping the blood flowing, and that it also helps with that. In addition
Yeah.
to the pump, yeah.
and then occasionally I've taken more, you know, like 10 milligrams plus a 50 milligram Viagra or something. But then I don't really see it doing anything, so except give me a headache.
Well, at this point, like Rick said, it might be too soon to expect any responsiveness. But as Alan pointed out, you know, you want to keep the blood flowing.
Yeah.
Cialis will help with that. Even if you don't see any benefit, it's keeping the blood flowing to the organ itself. That's my understanding. Do you agree with that, Alan?
Yeah.
Okay. All right. Anyone else before we move on to Mark? Okay.
Thank you.
Our pleasure. Mark. Hi. Thank you for bearing with us to the bitter end today. Glad you could.
Oh, that's all right. My pleasure. Just real quick review of my case. I had diagnosed in 16 or 15, 16, whatever, with stage 4 metastatic disease. Since then, I've had a prostatectomy and done chemo, done immunotherapy, Provenge, and then recently, once I had a PET scan, PEX Axiom, they identified that really a lot of my tumors, which I had initially I had maybe 2 or 3 tumors. I think a couple of them were really kind of just more arthritis than anything else. But anyway, they decided that I had the primary tumor was a T6 tumor. And so I got SBRT, 3 doses to treat that. And so I actually went from a PSA of around 6.5 to 3, and now I'm at 0.3. So I haven't had my PSA now for another, I have to wait for, I could have it this week, but I haven't gotten a recent PSA, but when I do, we'll have to see whether I would expect that I'm going to maintain that 0.3 level for some unspecified period of time. We'll have to wait and see, but that would be the hope. So and I don't think they'll do another scan specifically to look at, what was the effectiveness of the SBRT until my PSA starts to creep back up. Then they'll probably do another scan. So that's kind of my situation. I mean, beside that, same thing as everybody else. I'm on Lupron and, Zytiga and stuff. And so, or Xgeva, excuse me. And, I wish I wasn't on ADT, but it is what it is. And so I'm really doing pretty well. I really have very few complaints.
I mean, this is all really good news. I mean, I have a note that your PSA was up around 2.5 right around the time you were doing the spot radiation.
It got up to right before my radiation, or a month or week or so before. It had gotten up to 6 because it was greater than my PSA level was when I had my prostatectomy.
Wow.
I had a very low PSA level compared to the fact that I had metastatic disease. So,
Okay.
you know, I mean, the nice thing is initially radiation wasn't considered very feasible because, as somebody mentioned, I think Alan earlier, it's much more of a whack-a-mole kind of approach. But upon this PET scan, which showed that really the only significant hotspot was my T6, both the radiologist as well as my relatively conservative oncologist, they both agreed that going after the with an SBRT was a reasonable option. So we'll see.
Well, it's certainly better than considering Xtandi, which was something that we've talked about since the beginning of the year. At the beginning of the year, so you know you can hold off on that for a while.
I would hope so. I hope I could stay off Xtandi at least for the next year or so. We'll have to see.
That's great. So what did Dr. Stadler have to say about all of this? He must be happy.
Well, he was actually, you know, Stadler is much more of a why waste your time with whack-a-mole stuff, but he actually, because the T6 was clearly the hottest spot, and the only other place that really showed much significance was a pubic bone tumor that I've had since the beginning, but that seems to have regressed to its only slightly over background. So that's why they felt close that they were going after one target, not the old, you know, whack-a-mole, lots and lots of targets.
Right.
So we'll see.
Right. We you know, we like those stories when you get a good result from spot radiation, because to be honest, as Alan intimated early on, we don't see them often enough. And that's terrific. That's really terrific. Really. How are you feeling in yourself generally, and then you know your recovery from when was the last time you well, I was going to say, when was the last? You're still on your ADT.
Yes.
So, and you really haven't done another drug. So, you know, how are you feeling on the LHRH?
No, I'm feeling fine. I'm taking actually Trelstar. I find it, you know, it's not quite as hard for me to live with that, to manage everything with that than it was with Lupron.
Okay.
But I think that's more of just kind of a personal preference. You know, my physician's office, they get a deal from the drug vendors around Lupron, being able to stock it and so on. So they prefer if you use Lupron because it's just easier for them. But I tried Trelstar and I seem to be feeling pretty good. I've also done the Cialis thing. I really haven't, you know, it's not like I go around with a flaming erection all the time, but it's like, so I don't know if it's making a difference or not. It's really kind of hard to tell, quite frankly. But I'm in the early days. I've really been only on the 5 milligram maintenance dose for about a week. So we'll see after another month or so.
How's your exercise program?
Well, pretty good. I mean, I go to the gym 2 or 3 times a week if I can. I just played 18 holes of golf today, walking. So, you know, I have, I think, a pretty good energy level. I get out there and do it. I got to say that if I a couple weeks ago, I ended up playing golf because we've had so much rain in the Midwest, walking 3 days in a row. And by the last day, I was pretty much, I was ready for naps by the 12th hole. So, you know, I don't have quite the energy I used to, so.
God bless you. Well, if we can get you down to Tucson, I'm sure that Dennis will be happy to arrange a game with you.
That'd be great.
Yeah, we could do that.
Any questions?
Yes. Yeah, I'm sorry, you had a question?
No, I just said, does anybody have any questions about my situation? I think right now I'm back to kind of watchful monitoring, and we'll just kind of wait and see what happens with my PSA, and then you know, obviously then we'll have to talk about Xtandi or Zytiga, and probably Zytiga I prefer because I don't want to have to do the progesterone. But then we'll see.
Yes, well, you know, the downside with the Zytiga is the prednisone, although, of course, for Dennis, it wasn't such a downside because it seemed to handle a lot of his arthritic pain.
Yeah. So I'd probably rather do the Xtandi.
Right.
We'll
Can I make a comment about that? The prednisone you get with Zytiga when you're still hormone sensitive is just a replacement dose to replace the cortisol that's lost, because Zytiga stops your adrenal glands from producing any steroids, and you need a certain amount of cortisol in order to maintain good health. So they give you a replacement of only 5 milligrams per day. That shouldn't cause any long-term problems or any side effects at all. It's only when you take much higher doses of prednisone that you run into problems.
Right.
Yeah.
Right. Thank you. Yeah.
Good input. Thank you.
Agreed. Anybody else have any comments or questions for Mark? It's a great report. We've had 2 good reports to finish off with, 3 good reports to finish off with here.
And with that, Rick, I got to run because I have to be someplace. I'm running a little late. So
please.
Thank you. It's good seeing you all. It's good being seen. Okay, take care.
Yeah, I think we're closing up. We're closing off right now anyway. So yeah, we're right at the witching hour. So again, many thanks to Alan for joining us today. And Alan, you are always welcome anytime. Just come on in. Don't have to write me. We love to see your face, hear your voice. You are truly welcome.
It's a pleasure.
Thank you.
And I have a little question.
Great group of guys.
Alan, I have another question for you. Do you have a preference between Zytiga and enzalutamide?
No, I don't. The Stampede trials, one of the trials is going to address just that, whether one is better than the other. So far, they seem to be close to the same.
How about apalutamide?
That very good question, and I have no idea what the answer is.
Okay.
Apalutamide will be this coming weekend. There's a big conference, an ASCO conference, where they'll be talking about apalutamide and Xtandi in the hormone sensitive situation, metastatic hormone sensitive situation. Both appear to be good. I'll know more next week, but again, if apalutamide joins Zytiga and enzalutamide in the hormone sensitive situation, you'll have 3 drugs to choose from, which is wonderful in one sense, but the question is, do any of them work better than any of the others? You're asking a really good question. Maybe Stampede will do yet another trial testing apalutamide in with the mix to see if that's any better. But you're asking a good question. I just don't know the answer.
All right, good enough. Thank you very much.
Thanks. And I did want to acknowledge Larry Fish, who came on right at the end. Are you there, Mr. Fish? Well, maybe he stepped away.
No, hi everybody. I
Hi.
didn't. I was just muted. I just got to the tail end of the group. That's
Okay.
nothing special to ask or talk about. Thank you.
Okay. All right. So again, thank you, Alan. I hope you enjoyed the 2 hours as well.
What a great group of guys and a whole bunch of very interesting and insightful questions. The level of knowledge of this group is very high. I assume mostly because of your good ministrations, Rick.
Len has a fair amount to do with it, and we have a couple of other good guys. Len's background is a retired pharmacist. He's also on the DoD panels, and these guys are. We've got some sharp guys. What was nice tonight is we had the right number. Sometimes we can have upwards of 20, and it gets a little too crazy. So, we had a good number to have good conversation, so everybody had time and we didn't have to rush through anybody, and that's a real pleasure, as the guys on the call know. But thank you. Come back, and guys, we will be talking again on June the 3rd at 5 o'clock Pacific, 8 o'clock Eastern, and I wish you all a good week until that point in time. Good night, everyone.
Good night.
Good night.
Bye.
Bye, everybody.
Good night. Good night.